Well, thank you very much for coming to learn a little bit more about the Summer Capstone Experience for the Masters of Science in Nursing, the MSN, Clinical Nurse Leader, CNL students. This is the first time this course has been taught, and we're very grateful for your participation. We'd like to give you a little bit of information about how this summer experience is going to go and provide a forum for you to ask any questions that you might have. So again, this is the first time this course is being taught. It will be taught the full summer semester, which is 10 weeks over the summer. What we'd like to do is to discuss briefly what the role of the clinical nurse leader is. That might be a role that you're not real familiar with. Talk a little bit about the basic components and the expectations for this specific experience in their program of study. Talk a little bit about your role as preceptors, and then recognizing that the students do have a capstone project that they will be producing, give you a little bit of information about what that project involves and how you might be most helpful. So the clinical nurse leader role is a specific nursing response to the Institute of Medicine review of the issues and barriers to optimal healthcare in our system in the United States. And they really identified these areas where healthcare has some opportunity for improvement. That is patient safety, effectiveness of care. Sometimes we do things that are not optimally effective. Sometimes we do things in redundant ways or other kinds of inefficiencies. Sometimes there are delays in patient care and things could be more timely. Patients are often the last to know about some of the decisions or some of the options that might be under consideration, and so how could we move the system to be a bit more patient-centered? And we know that we have disparities, and we would like to have things be addressed so that things can be delivered in a more equitable way. So specifically, how does the CNL role contribute? This is a different role in that this is a master's prepared entry point. There are a variety of models for this master's education. This particular model is for people who have a degree in something else, who are preparing to be generalists and really lead change at the unit level. The current terminology for the unit change leader is the microsystem leader. And they are really looking at making a difference in those areas that the IOM pointed out. So patient safety, effectiveness, timeliness, and so forth. So in addition to learning to be a nurse, these students are learning those specific tools, methods, and measurement kinds of strategies that they could really take a project and bring it to fruition and make a difference in those areas of system-wide healthcare. The AACN did come forward with those 5 models, and again, this is a Model C, so these students all have a baccalaureate degree in something. They do range widely in what their prior degree was in. They are novice clinicians, so they are at about the same point as a new graduate BSN student. So they do need precepting still with their bedside proficiency. Their academic preparation does differ from a generic BSN in that they have 4 additional leadership courses prior to this experience, and then they will have this 6-hour academic preparation this summer that really focuses on unit level change management. So prior to this summer semester, these students will have had all of their core courses, so maternity, geriatrics, pharmacology, pathophysiology, and so forth. 3 clinical courses, or 585 clinical hours, 14 simulated care experiences in the Nursing Clinical Education Center, and those 4 graduate leadership courses. So this experience goes from the 26th of May until the 31st of June. During that period of time, the students, 31st of July, during that period of time, the students will be focused on 1 unit, recognizing that the research that's been done by the Institute of Medicine and the Institute for Healthcare Improvement really demonstrates that top-down change initiatives don't work very well. Where the care is delivered is at the unit level. Units have their own personalities, they have their own strengths and weaknesses, and change is really much more likely to be sustainable if it's developed and implemented and nurtured at a unit level. So for this experience, we want the student to stay in that same unit for all 10 weeks with a consistent preceptor who helps them polish their professional practice. They will be there for 315 hours over that 10-week semester. 275 of those hours will be as direct care providers, so they should have a patient assignment and they should be doing as much of that care as possible. And then they'll have, for the second half of the semester, the second 5 weeks, approximately 10 hours per week where they will have dedicated time still in the unit or in the organization to work on their capstone project. So the core competencies that the American Association of Colleges of Nursing developed are that in addition to being clinicians, these individuals will demonstrate advocacy and leadership in the profession. They will demonstrate that they have proficiency in information management and being able to analyze risk and optimize clinical outcomes. They'll be really working on looking at patient cohorts. What are the needs and issues that that cohort of patients has? What are opportunities where nurses could make an impact, where they could influence the process of care or the outcomes of care in a positive way? And how can they elevate the standards of a whole team of practice using evidence to guide those decisions? So the goals are for the students during this experience to enhance their clinical reasoning, to go beyond tasks and really think about the whys behind the practice of nursing and build those connections between facts that they've learned in their classroom experiences and real life and how that plays out at the bedside. We want them to really work on priority setting and delegation. We want them all to do a tracer so that they understand where the patient came from, where they need to go next, and what are the hallmarks that indicate when a person is ready to transition, and what are the things that make those transitions work well, and where are there issues with those transitions. We know from a lot of the patient safety literature that errors happen when people give handoffs. Omissions in communication are a potential place for errors to occur. And so we really want to look at what are the ways that handoffs can be standardized and optimized. And how do teams make a difference in the way that clinical outcomes are able to be produced? So how do teams come together? What does a high-functioning team look like? What are barriers to team functioning? And how does a new person insert themselves into a team as an influencer? Last, we listed it last intentionally, they do still need to practice some of their bedside clinical psychomotor skills. This is probably the area that the students are most interested in, and we want them to have those experiences as much as possible, but we want them to really practice putting them in a broader context. Some logistics about how the course is going to go this summer. We do have class on Tuesday. Class on most Tuesdays will be from 9:30 in the morning until 1:30 in the afternoon. So it's very possible that a student could have a 3 to 11 shift or a 7 p.m. to a 7 a.m. shift, but on Tuesdays they are not available to work the day shift. Other than class, students can work the schedule of the preceptor. So if the preceptor is working nights or 4th of July, that would be a time that the student could be expected to be on duty as well. Days, evenings, weekends, very doable for students. Nights we have some concerns about. If the preceptor is really a strong, very passionate, very interested educator, it's a possibility to make the night shift work. We understand fully that clinical activity happens 24/7. On some units, there's more clinical activity than others on the night shift. So if this is a unit where the patients are largely in bed and asleep by 9 o'clock, may not be optimal learning families are not around, other team members are not around for the student to practice their collaboration skills. And most of us learn better when we're awake and alert, and so it's tough for the student to learn. On the other hand, as I said, if we have a really outstanding preceptor and they work the night shift, we wouldn't rule that out. It's certainly easier for the student if they're not flipping back and forth days and nights. If the preceptor is expected to be consistent across the 10-week semester, we do want to be practical and realize absences might happen. If a preceptor is ill, we don't want the student to be on the unit without any supervision. So we do want to have some planful anticipation and thinking ahead. If you have a student that you have committed to mentor for this 10-week period, we would want to build links so that if there is an absence, that preceptor has a plan of who's going to be their backup individual, and that student can be handed off so the student knows who they're going to be with, and the individual they're going to work with knows that the student is their responsibility and what the student can do, has done, and needs to work on from this point forward. This is the model that we're really looking at. We're hoping that the preceptors will really role model professional practice in its fullest sense, will help the students to socialize. There are a lot of unspoken norms in nursing and lots of research that's demonstrated that in the first year of practice, that's what gets people. They don't know the things that are going to be perceived as uncomfortable or unacceptable in a work group, and this would be a way that we could really help them, to give them those kinds of cues. And then to really educate them, both in terms of professional opportunities and in terms of clinical practice. So what are we looking for from you as a preceptor? We're looking for you to really take this individual under your wing. As a mentor, that you would introduce them, that you would ease their way into the team on your unit, that you would really look out for them and help to design learning opportunities where they could really flourish and grow. So the kinds of learning opportunities might vary based on what the student comes with. So early on, it'd be nice to have a conversation about where they feel like their strengths are, where they feel like they really want to concentrate in this relatively short period of time, and how they learn best. We would hope that you will help them by locating or creating learning resources. Some people do really well by just reading things off the computer. Some people read best on paper. Some people are not readers. They're tactile learners or auditory learners, but to help them create those or locate those resources that would help them to learn the things that they have as their learning goals in this summer. Be aware of what their competencies should be at the end of the program and help them find opportunities to work towards achieving those goals. And then give them real-time feedback. There's nothing more frustrating than to come to the end of an experience and have somebody say, you know, this person was a dud the whole time. Had they known at week 1 that there was something that wasn't working well, they would have had an opportunity to make some adjustments. And having that real-time feedback would be very useful. So what's the student expected to do when the faculty comes? There is a presentation of a patient, so we will notify the student when the faculty will come, which will be no less than once a week. And the faculty will be expecting the student to talk about who are you taking care of, what is their reason for being in the hospital, what are you doing for them, what are the transitions that would be expected in the normal course of care, and what are the resources that a patient would need to make those transitions successful. Those format documents are in the packet. You are not expected to participate, realizing that you are busy. It would be something that would be useful for you to know what the student is expected to prepare. If you do have time and want to participate, that would be fine, but we don't want to really impose upon your time constraints. Would be useful for you to make certain that the student knows where the data is so that they can do a very thorough job. So for example, if they're presenting on a patient who has relevant lab results, it would be important for them to know where do they find those lab results. So as a direct care preceptor, what we are looking for is for the student to do as much of the direct care as possible with your daily guidance. They are not yet licensed, so they are not at a point where they can be independent in high-level critical care settings or in any setting where you would have concerns about whether or not the things that they are doing are license requiring. We do want them to be doing, not watching you do, as much as possible. The preceptor will be asked by the faculty at the middle of the semester for a formative evaluation and for a final evaluation at the end of the semester. The faculty will also be using the Advisory Board Readiness to Practice tool, which looks at if you were hiring this person on your unit, if this was a new graduate, how ready would you feel giving them a full assignment on your clinical setting? And the expectation is not that you would be 100% ready, that there would be some areas for the average new graduate where they would need to polish and develop, but that you would give them kind of a hallmark of where are they now and where do they need to invest some energy to progress towards being really proficient. Each of these students will also have a secondary preceptor that will help them with their project. So again, thinking about their end of program competencies and those IOM aims, their project might center on something like a delay. And so the preceptor for those kinds of activities might vary depending on what the effort of the student is. If their project has to do with delays, they might have some need to interact with individuals like patient representatives. If their project has to do with outcomes, the quality department in your hospital might be more appropriate. But somebody to help them really access the resources that would help them facilitate their project. Then what will the faculty be doing? Again, the faculty will be making at least weekly visits. They will be working with the student on that presentation so that they really practice getting the flow down for how do you, in a concise and organized way, talk about the clinical condition that a patient is receiving care for. They will be assessing the student's readiness to enter practice, and they will be assessing their progression towards mastery of the CNL competencies. The faculty will assign the final grade for this course. The faculty is very interested in both preceptors' input into that grade, but are not expecting that you will make that final determination. So the student does do this capstone project. They select one of those areas of the IOM aims. I would hope that they will do that in concert with their individuals in the unit so that the project that they select has some utility for the unit that they work on. So you know your units well, you know what areas you really have some opportunities in, and that you would help to guide them to select a topic that would be appropriate. They have project data needs. So again, for example, if what they're looking at is pressure ulcer development, what they might need is what is the rate of pressure ulcer prevalence on your unit? What are the interventions that have been tried, and is there any efficacy data for those kinds of interventions? They might need to be connected to a wound nurse for a project like that. Again, about approximately 40 hours of their on-unit time will be spent developing that project. We have a list of sample projects from CNL students and other programs in your packet, if that would be helpful to kind of see the sorts of things that people take on. Their projects are due by the 26th of July. And then on the 29th and on the 30th, each student will give a 15-minute presentation. This is intended to give them some practice as though they were speaking to a professional audience at a national conference. So they really will be 15-minute professional presentations. At the end of 15 minutes, even if they're half finished with the remarks they would like to share, their presentation is over. We would like to have any and all preceptors come and listen to their students or any of the other students' presentations as part of the professional audience. The students then graduate on the 31st of July. So we are hoping, given this is the first time this course has been taught, that we will have a very dynamic and free-flowing discussion about what's worked well, where this could be improved, what really stood out as this did not work at all, so that we can enhance this experience for the students who will graduate in 2010. So to that end, we've established a blog spot, and we'd like to put up frequently asked questions, answers, thinking that might be a most efficient way to share that kind of information. We are so grateful for your investment in the learning of our future colleagues. We want this to really be a fun experience. We want it to work well and be efficient for you. In your packet, we provided a bunch of materials, and we don't want people to wait until the very end if there are comments or questions. Please feel free to email or pick up the phone for any of the faculty that are involved, and please feel free to use the blog spot. Thanks so much for your time and attention, and we look forward to working with you.